Good evening to all. I warmly welcome you to our CellTalk webinar. In today's session, Mr. Numer will be presenting the research phase 1 study of zotiraciclib in combination with temozolomide for patients with recurrent high-grade astrocytomas. Our speaker Numer is a clinical content writer at Renix. He is responsible for writing scientific medical white papers and blogs. His work is centered around making complex scientific concepts accessible to lay people. He is currently pursuing PharmD at Lahore University. His writing at Renix focuses on precision medicine for cancer patients. Numer is currently working on gene map projects and delivering scientific content that aims to provide gene centric information for various diseases and their treatments. Renix has allowed him to gain leadership in various projects related to content. So, without further delay, I would like to call upon Numer to take over the session. Over to you, Numer.
Thank you, Yogita, for such a kind introduction. So the topic that I am presenting today, it's based on the article that's titled as Phase 1 Study of Sotiraciclib in Combination with Temozolomide for Patients with High-Grade Recurrent Astrocytomas. It is originally authored by Wu and others, and I've taken this article from Clinical Cancer Research. Its impact factor is 13.8, and this particular article is published in 2021. It has its impact on high-grade astrocytomas, and these are anaplastic astrocytoma and glioblastoma multiforme. So before going much into the article and the research that they did, let's have a look at the astrocytoma and what they are. Astrocytoma, they are a type of brain tumors. They originate from mutations in the glial cells. They are star-shaped glial cells called astrocytes, which give rise to these astrocytomas. And they're divided into four types. These four types, they behave differently in terms of their clinical nature and their aggressiveness, and they correspond to four different WHO grades. So the first one is pilocytic astrocytoma, then diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma multiforme. These last two, anaplastic astrocytoma and glioblastoma multiforme, they are also called high-grade astrocytomas, and they are the focus of this research. Then general background of high-grade astrocytomas is that they are very aggressive in their nature, and they often resist to the therapy that is conventionally used against them. For this reason, they often recur and they lower the survival rates. The drug that is being used in this clinical trial is one is the temozolomide. That's a very well-known drug, chemotherapy drug for brain tumors, and the other is relatively novel drug that is called sotiraciclib. It's been used in hematological cancers before, but this is the first time that it is being used in astrocytomas or brain tumor. It was called TG02 in the animal studies or preclinical studies, and it is an inhibitor of cyclin dependent kinases or CDKs. Specifically, it inhibits the CDK9. CDK9, it stimulates the cell division and growth by stimulating the RNA polymerase 2. So the present challenges are that these high-grade astrocytomas, they are very heterogeneous, so they resist a certain subset of cells within these tumors. They resist to the conventional therapies that we have against them, so they often result in a recurrence of these tumors. And once the therapies that we have, they are not working, we don't have a lot of other options. So the objective of this research is relevant to the this recurrence and the resistance, that we are trying to give more options in cases where the high-grade astrocytomas, they are resistant to previous therapies. And specifically talking, it is a phase 1 clinical trial. It will be evaluating the safety and schedule of therapy. So it's a combination therapy, sotiraciclib and TMC, and it will be also looking into some sort of efficacy, not a lot, but just the preliminary efficacy. The major target will be the safety. So moving on to the methodology, the study design, as I talked earlier, it is a phase one clinical trial. But within that phase one clinical trial, they've divided into two parts. The first part is dose escalation, and the second part is cohort expansion. So its primary objective is to assess the safety and preliminary anti-tumor activity, and they will be looking into the dose limiting toxicities as the primary safety endpoint, and the secondary safety endpoint is the progression-free survival at 4 months, or PFS4, and also considered the patient-reported outcomes, or PROs. And in both the clinical trial, there are two arms, and in both these clinic arms, the patient will be randomly assigned. In the first arm, TMC will be given as dose dense, or DT. What dose dense means is higher doses of TMC is being given, but they are given intermittently, like there are some sort of interval between them. And then the other arm is being given metronomic TMC. This means that low doses of TMC are being given, but they are continuous. And in both these arms, sotiraciclib is also being given. So the dose of TMC is already determined in both these arms, and because TMC is a conventional therapy, and a lot of work has been done on its dose determination, but the objective of this clinical trial is to just evaluate what sort of dose could be given of sotiraciclib in combination with TMC. So they're starting out with 200 milligram. They will either lower the dose 50 milligram and come to 150, or go 50 milligram up and go to 250 milligram, and similarly 300 milligram. And this escalation, this will be decided by, or dictated by, Bayesian optimal interval design, or point design. And they will be determining the maximum tolerated dose, or MTD. So let's talk about the patients. How the this clinical trial recruited its patient. What was the criteria? Uh, First, it's apparent that the patient should have the recurrent anaplastic astrocytoma or glioblastoma. Uh, Second thing is the tumor should be recurrent, but they were not taking any patient who has more than two relapses. And then the KPS was should be 60 or above that, and the patient should have adequate organ function. And pregnant or nursing women, they were excluded from this clinical trial. And one important thing is there are certain enzymes, a family of enzymes called CYP enzymes, and they can potentially affect the mechanism, the metabolism of sotiraciclib. So they, in the criteria, they excluded those patients that were taking those sort of drugs that were known to inhibit some of the, or inhibit or induce some of the CYP enzymes. And then this clinical trial took place at the Center for Cancer Research of the National Cancer Institute in Bethesda, Maryland, USA, and it was in accordance with the Declaration of Helsinki Principles, and it got the institutional review. It was approved by institution and NCI, Institutional Review Board, and the patients gave their written informed consent. Moving on to the treatment, as in both these arms, both arms were receiving the TMC, and zotiraciclib was combined in them. So in the first arm that was being given the dose dense TMC, it was given as 125 milligram per meter square, uh, and it was given on days 1 to 7, and then 15 to 21. And the other arm that was receiving the metronomic TMC, it was being given as 50 milligram of TMC per meter square of their body surface area. So And sotorasib, it was already given along with that. Remember, it's a combination therapy, and they are looking into the combination of sotorasib with TMC. So they started out with 200 milligram per day orally, and they didn't give it all of the days during the cycle. So the cycle was 28 days, and they didn't give it all of the days in that cycle. They gave it on the first day, 12th, 15th, and then 26th day. And this escalation and de-escalation, as I talked earlier, it was dictated by point design. Then moving on to the part two of this clinical trial, which was cohort expansion. So the purpose of the part one was to establish the MTD, or maximum tolerated dose. And once the MTD was established, they expanded both these arms, and they let it continue for 12 cycles. In the study assessment, they performed the physical exams and then laboratory examinations and MRIs, and it was performed on baseline, like before the clinical trial, and then every 2 cycles to determine the treatment response. And then there was some additional assessments. There were three additional assessments. The first one was the pharmacokinetics, like how zotiraciclib is performing in the body, like how its concentration is increasing and decreasing with the time, how it is being absorbed across various biological barriers within the body. And then pharmacogenomics, it is it also evaluated how different people with different ethnical backgrounds they dealt with zotiraciclib, because different people, they can have different CYP system enzymes, and CYP system enzymes, they are responsible for the metabolism of these drugs. So they also looked into pharmacokinetics. And then also for the neutrophil analysis, they looked into it, because there are chances that these sort of drugs, they can have impact on the white blood cells. So they also looked into neutrophil analysis. And for this purpose, they carried out various tests, CBC with differential, and then ROS production and chemotaxis by neutrophils. And for the genomics, they also looked into the genotype for various types of CYP enzymes. So these are the two enzymes that they specifically looked for: CYP1A2 and CYP3A4. This is the overall design of the study. You can see that they started out with 53 patients that they enrolled, and then these both arms. This is for the dose dense, and TG02. It's the same zotiraciclib. It was the name that was given to it in the preclinical studies, and this is the metronomic arm. So once they determined the MTD, then they moved on to cohort expansion, and then they looked into the secondary outcomes, which was the PFS4, and then also they performed into some exploratory analysis that was pharmacokinetics, pharmacogenomics, and neutrophil analysis. Moving on to the results, so they recruited 53 patients, as you saw in the flow chart earlier. It was between December of 2016 and December of 2019. And then afterwards, once they established the MTD at the end of part one of this clinical trial, they randomized 13 patients in both these arms and expanded that to 12 cycles. And then the patient characteristics, they were similar, because they were randomized in both these arms. And the classification of astrocytomas, it was taken from the WHO classification of tumors that was published in 2016. In terms of safety, as it is expected that the dose limiting toxicities, or DLTs, they were proportional to the dosage of sotiraciclib in both these arms. It only makes sense that as the concentration of sotiraciclib, it was rising in the blood, then the dose limiting toxicities, they were more severe and more frequent. And in both these arms, once they carried on with escalating the dosages. Once the two patients reached the 300 milligram of sotiraciclib, they found that one of those two patients had severe dose limiting toxicities and had to be admitted to ICU. So that gave the investigators an idea that 300 milligram, it is the limit, that they cannot go to 300 milligram, and they reverted back to the previous increment, and that was 250 milligram. So 38 patients, they had the DLTs, but they were not very severe. So this is the primary outcome that they came up with, because while reaching at 300 milligram, they found that a patient was had to be admitted to ICU, so they reverted back to 250, and they recognized 250 as the MTD, or maximum tolerated dose. And then there were some additional findings that two patients, they gave response to this treatment, and both patients had IDH wild type glioblastoma, but one had unmethylated MGMT. These are some extra findings that they came up with, but 250, this is the number that they were looking for. This is the MTD of sotiraciclib in combination with TMC. And then more into the outcome, they in the secondary outcome, they found that the in the arm one, that is the dose dense TMC, the patient showed 0.40 or 40% PFS, that is progression free survival at 4 months. It was 40% in arm 1 and 25% in arm 2. So this clearly tells that it is not a big difference, but it tells that the arm 1, or the dose dense TMC, combined with 250 milligram of zotiraciclib, it's a better schedule for this combinational treatment. And they went with these that they suggested these schedule to be followed in the further studies, like trial phase 2 and 3. It can follow this dose dense TMC in combination with MTD of zotiraciclib. And then there was a special adverse effect that came as a result of this clinical trial. It was transient neutropenia. So what they found was the number of neutrophils, the absolute neutrophil count, it reduced between 12 to 24 hours after taking the zotiraciclib, but it recovered after 72 hours. So you can see this trend in this graph here, that as the patients took the oral medication, so oral medication, it takes some times to receive the maximum bioavailability in the drug, as opposed to the intravenous drugs, because they are inserted directly into the blood. But for the oral, it takes some time, so it took some time to reach the maximum dose. But at that time, the neutrophils, they were very lower in number, so they started coming down as the drug reached its maximum concentration in the blood. But once the metabolism picked up, and CYP system enzymes, they started metabolizing and degrading this drug from the blood, so the neutrophil count, it went up again. So this is the transient neutropenia. So you can see that the at 12 hour mark, the number of neutrophil is lower as compared to 48 and 72 hours. And this can be correlated to the concentration of zotiraciclib in the blood. So it started lower, then once the maximum concentration was reached, afterwards the body started metabolizing it, so its concentration went down. And you can compare it with the previous graph like this. These two are basically opposite to each other. So the neutrophils are going down concentration of when the concentration of zotiraciclib is going up. And basically same for the rest of this graph, like after the 24 hours, the drug is reducing, but the number of neutrophils, they started picking up. Another thing that they looked into is the chemotaxis, and they used various markers for that. One is the FMLF, and then C5 A. These are the chemicals that this is the complement protein and other chemicals that they uh, induce the chemotaxis of neutrophils. So they looked into that whether this chemotaxis is affected or not, and they found that it was not affected. Another thing that they looked into the production of ROS or the reactive oxygen species, but it was affected, and they found out that in response to these markers, it was affected, but it was only transient. Like the absolute neutrophil count, it was lower up to 12, up to 24 hours after taking the zotiraciclib, clip, but it recovered by 72 hours. So it is also transient. The expression of cell surface antigens, it was not really important, but it also showed that they also carried out a few analysis into the cytokines that were there in the body. So they also found that it was having some impact on the cytokines, but as with all other properties, they recovered up to 72 hours. And then you can see it here, the neutrophils. This is the normal, that this is the normal established value, this is the baseline value, and this was the value after 24 hours, and this is the value after 72 hours, and these are different markers for ROS production. Like the ROS production is being induced in response to these three markers in the body. So you can see the same trend here. Like after 24 hours, it's being reduced, but it is bouncing back after 72 hours. So this also shows the transient nature of this effect on the neutrophils of sotiraciclib. Same thing you can see here. And then moving on into the pharmacogenomic studies of zotiraciclib, you can see it here. Like different patients, they have different types of CYP system enzymes in them. There is some sort of heterogeneity in that. So different populations can have different enzymes, and you can see it here that they are having some sort of effect on zotiraciclib concentration. So this can be more useful in terms of precision medicine, like when giving this in combination with TMC, people can undergo examination, pharmacogenomic examination before, and the clinician can adjust the concentration of the dosage of drug that is being given to them. And also it can guide future studies, like the phase 2 and 3, they can incorporate more about the pharmacogenomics, that they can recruit patients from different regions of the world, that they have different CYP system enzymes. So it can give us better picture into how zotiraciclib, how its concentration varies among different individuals. So in the discussion, basically they carried out this phase 1 clinical trial. It was divided into two parts. Uh, First one just established the MTD, and the second one was mostly focused on how this MTD is doing in terms of efficacy of the drug. So they use the Boyne design to basically design all of the dosages that they gave, and escalate and de-escalate depending upon the response that they were getting from the patients. And then in the secondary outcome, they found that this PFS4, it can guide the future studies like phase 2 and 3. It can be useful for that. And pharmacokinetics and pharmacogenomics, it can also be utilized into future studies and better studied there. But one thing that can be really beneficial is that they helped identify this very novel side effect of this zotiraciclib, that was the transient neutropenia. So it can be better studied in future drugs, but in this one, they did a lot of analysis, and they found out that it is not really a cause of concern. It does cause very severe symptoms up to 12 or 24 hours after taking the drug, but those symptoms they can reside after 72 hours. So this can be useful when guiding the future clinical trials. So, in conclusion, they just established the safety and tolerability of this combination drug, that is TMZ with zotiraciclib, and they found out a new adverse effect, that is transient neutropenia. So, this can go into further studies, and it can go into phase 2 and 3 clinical trials. Impact of this study is that it can contribute to more therapies that are being used in high-grade astrocytomas, like whatever the treatments that they are there. If patient is resistant to them, then it can be given. And another thing is, if zotiraciclib is being given in other types of cancers, so having very detailed information about transient neutropenia, like how it affects the number of neutrophils over time, and how it affects the chemotaxis and ROS production, and cell surface markers and cytokines. This all information that they provided in this clinical trial, it can be very helpful in planning not only the future trials in this astrocytomas, but in other types of cancers as well. Thank you so much.
Thank you so much, Numer, for this enlightening and informative talk. Now I open the floor to the audience. Vijay has a question. Why there are any improvement in PFS in IDH mutant subgroup?
Well, it was something that they found along the lines of this clinical trial. It was not the primary or even the secondary objective of this clinical trial. My understanding is that it can be more related to TMZ, but it can be further looked into with respect to zotiraciclib in further trials.
Okay, hope it answers your question, Vijay. Nupur has a question. It seems dose is less effective for wild type IDH. Is it?
Yeah, it is less effective for wild type that they showed in the. Again, this is the same point related to the mutational profile of the tumors, and it did have some varying effects on that. So, the future trial can definitely look into patients and even recruit patients, or have different arms of those clinical trials that are based on this mutational profile, and their efficacy can be better monitored there. And not in only this mutation, but MT methylation status, it was also having some impact. It is not clear whether the effect was mainly because of sotiraciclib, because TMZ, we already know that it does have some impact on that. So the future trials, they can evaluate better on these lines.
Hope it clarifies your doubt, Nupur. Numer, I have a question. Does zotiraciclib is currently being utilized in the treatment of any other tumor?
It was trialed for various hematological cancers, but according to my knowledge, is not being utilized anywhere else.
Okay, thank you, Numer. Does anyone have any question? I don't see further questions coming from the audience. So thank you, Numer, for the excellent presentation. I'm sure many of us can have a takeaway from this. Numer, can you go to your final slide? Thank you, Numer. Before we conclude this webinar, I would like to inform everyone that our next presentation will be on 7th Feb 2023. And Ms. Aditi will be presenting research titled Brain Tumor Patients Use of Social Media for Disease Management, current practices, and implications for the future. I would like to thank you all for your time and kind attention today. Thank you all for being here. Hope to see you all at the upcoming presentation. Thank you so much.